Welcome to the Sri Lanka Surgical Congress 2024. It is our honor to guide you through today's sessions, which promise to bring forth valuable insights and advancements in surgical practice.
Kicking off day one here at Eagle Hall, we have a series of symposia covering a diverse array of surgical topics. These sessions are sure to be both insightful and enriching for all attendees.
Let's begin our day with Symposium 2 titled Vascular Symposium, Diabetic Foot Diseases. This symposium will focus on diabetic foot diseases, which represent a major complication of diabetes. It will highlight the nature of the disease, its management, and the red flags in diabetic foot diseases.
Good morning. I welcome you all to the Diabetic Foot Symposium. I'm waiting for my slides. Because we have, the time is restrained, I will just get on with it. That's not that. So, we all know diabetes is a global problem. It's the fourth leading cause of death, and diabetic foot ulcers is really a sequelae of diabetes, and it's a huge economic burden. And once you get an ulcer, that's like you can easily end up with amputation. So ulcers and amputations cause a huge economic burden, and for the patient is a big problem, and being an amputee increases mortality, and it leads to very poor quality of life. So my job is to give an overview of the diabetic foot disease. And let's get on with it. Move the slides. I know it's the first lecture, so lots of glitches happening. Yeah. So it has a lot of pathologies together. When you talk about the diabetic foot, there is a neuropathy, there is a peripheral vasculopathy, there is an immunopathy and Charcot's neuroarthropathy. All these leads to foot ulceration, and there is osteomyelitis, the infections of the bone, and also structural abnormalities. So all these comprises of diabetic foot, which is a complex problem. And why are we so interested, as I mentioned before? Because it has a high incidence of ulceration, 1 to 4%. It has a prevalence of 4 to 10%. So this gives a huge economic burden, and there's a lifetime risk of ulceration of diabetes in 25%. Every 30 seconds, there is amputation happening, a major amputation. 80% of these preceded by foot ulceration and can be prevented. And 80% of all these non-traumatic amputations are due to diabetes. And once you get amputation, it's like a death sentence. Mortality is so high. First year goes up to 40%, and 5 years it's up to 80%. So it's like a death sentence once you get amputation. So just looking at the pathogenesis, as I mentioned before, there's a neuropathy, which is, there is a sensory neuropathy of glove and stocking type. There is a motor neuropathy, which causes a small muscle wasting and deformities. And there is a sensory neuropathy, motor neuropathy, and autonomic neuropathy, which gives rise to a dry skin and cracks, and which again leads to ulceration. Vasculopathy is the occlusion and stenosis of vessels of the tibial vessels. The popliteal is spared, and the distal vessels are spared. And they also have a microangiopathy as well. Charcot's neuroarthropathy is another condition which causes midfoot collapse and eventually leads to amputations. Immunopathies, they have neutrophils polymorphs don't function well, so they are more prone to infections. Once you get an infection, they end up with sepsis. And poor glycemic control is also implicated in poor wound healing and amputations. Before these things happen, we have to identify the high-risk foot so we can intervene and prevent ulceration and amputation. So neuropathy, having vasculopathy, having structural abnormalities, even dry skin, fungal infections, nail changes, all gives rise to a high-risk foot. History of ulceration also is implicated. Then long duration of diabetes, more than 10 years, poor glycemic control, even the footwear matters, so you have to wear the right kind of footwear to prevent ulceration. And impaired vision is also causes a high-risk foot. Neuropathy, as I mentioned before, you have to get a good history about the neuropathic symptoms and inspect for all these callosities, hamartomas, and all the pressure areas. This is the painless nature of the foot disease. You can put a needle through. This is the motor nerve damage, which gives rise to a clawing and bunion formation. This is the autonomic neuropathy, which I mentioned before, leads to drying of skin, cracks, and this is how you assess the neuropathy. Monofilament test, a 10-gram monofilament test, and also you can use a vibration sense with a fork, tuning fork. And then you have to look at these structural abnormalities, which gives rise to callus, the bunions, the hammer toes, the claw toes, the fat foot, and also look at the joint mobility. So they have fixed joints, and there are devices which check the pressure. So before you cannot wear just any kind of shoes, you have to check the pressures and ideally wear off-loading shoes. Charcot's neuroarthropathy is also a disease entity. You have an acute stage which mimics cellulitis, so you should not treat it with just antibiotics. And in the chronic stage, it becomes a painless mid-foot collapsed foot, with eventually leads like a rock bottom feet. I will show pictures. This is what I mentioned. You have to look for callosities, you have to shave them without causing an ulcer, and at this stage you have to give them proper shoes to avoid ulceration. This is once we have failed in the shoes and identifying these pressure areas, they ulcerate. So in this case, you have to shave off the callus and offload these. This is showing the Charcot's foot. You can see the mid-foot collapse. There is no arch like the normal foot. You can see the rock bottom nature of the Charcot's foot. Let's move on to the vasculopathy. So I told you it has tibial vessel disease. So they have generally a popliteal pulse, absent distal pulses. Claudication is uncommon because they have neuropathy. It masks the claudication symptoms. And we do ankle brachial pressure index in normal cases, but it's not indicated in diabetics because of the calcification. Ankle brachial pressure becomes unusually high. Toe pressures can be measured, and less than 30 is considered peripheral vascular disease. And duplex scanning also helps, especially in planning bypasses. When you take the diabetic and the non-diabetic, this is how it looks. In diabetics, it's mostly the tibial vessels which are involved. In smokers and other peripheral vascular disease, it's more proximal vessels which are involved. How do they present? So somebody does an amputation without checking the pulse, and then it goes desiccated, dry and black, non-healing, or sometimes like this, ischemic and infected. You can see the infection has spread up to the midfoot, or like this, multiple debridements, ends up with a desiccated dry ulcer. This is a pressure ulcer, which is ischemic. You can see the dry, the desiccated nature of non-healing nature of this. So, together with neuropathy and vascular assessment, the ulcer assessment is very important. There are a few scores which are available, like the PDIS, the perfusion, extent, the depth, the infection, and the sensation. It covers all the areas. Then there is Wi-Fi scoring. We usually use Wi-Fi scoring. Then when presence of infection is very important, the surrounding erythema, fever, pus discharge in them. So there are some blood tests which we can do, and also there are X-rays which will lead to, which we will see osteomyelitis, MRIs, bone scans, it's rarely done. So it's polymicrobial, this infection. In osteomyelitis, we have to suspect it when it's non-healing, and indirectly they will have a high ESR, and also will be X-ray evidence of osteomyelitis. So we have to really assess the ulcer and show some examples in the future. So this is a neuropathic ulcer due to pressure. So you need to excise these scalars, shave these scalars off, and then offload it. This is what we do in our practice, because they are known to have, people are non-compliant, so if you just give them a footwear, they do not wear it at home. So this keeps it on, and they come back with the dressing on in the next visit, and it's offloaded. But you have to tell them not to walk outside because the rest of the foot is not protected, but this works very well in our patients. This is an instance where we would like to call like a diabetic foot attack. So this is a infected foot, usually by a prick injury, and then it really spreads fast. You have to do a thorough debridement, take all the necrotic tissue off, and treat with IV antibiotics, glycemic control, supportive care in order to save these feet. This is another instance. You can see this skin is, you can see the skin peeled off, otherwise you will not see it. You will just see the necrotic toe, but you see the infection has gone up to the midfoot. On the dorsum, so this needs a debridement like this to remove everything. So this is ischemic and infected ulcer. For them, we do distal bypasses. From posterior tibial or to anterior tibial, this is how it looks, the vein with a 7-oproline to the distal artery, and this is how a necrotic dry wound can be transformed after bypass with slow granulation tissue and then covering the entire foot. This is a neuropathic burn injury in a peripheral vascular disease patient, which after a bypass and proper wound care starting to granulate. This is osteomyelitic ulcer with bones involved. After debriding the bones and a vac dressing, you can get them to granulate and heal these. This is unseemingly, just a little hole that you see in the foot, but you can probe it and squeeze it and you can see pus pouring out. So you have to treat these concealed collections in order to heal them. It's another example. You can put the artery faucet through and through, and this patient, you can put the finger through and you can see a lot of necrotic tissues underneath. So in order to heal these, you have to act fast, identify the rapid nature, how it spreads and becomes septic, and you can end up with amputation. So you have to revascularize, you've got to debride, you have to give the right antibiotic, control the sugars, and in order to heal these. And some of the successes, extreme cases that we have salvaged, taking all these into account. So diabetic foot disease is a complex issue with a lot of mixed pathologies, and in order to heal them, you have to have the right tools with you. When you want to revascularize, you have to immediately revascularize. When it's neuropathic, you have to offload. When it's infected, you have to do a thorough debridement, give the right antibiotic and the supportive care in order to heal them. Thank you very much.
Next speaker is Professor Mandika, and this audience doesn't need any introduction. He's a professor of surgery from University of Lanka and a consultant vascular surgeon.
Thank you. Thank you, Ranjuka. I think Ranjuka did more than half my lecture. Slides. Yeah, debridement. You showed some really nice pictures, and I knew you would, and I didn't bring many pictures this time. Yes. Even the chronic ulcers start acute. I mean, there is a beginning. It doesn't just happen. Some trauma, and as previously mentioned, neuropathy, easy wounding because of loss of protective sensation, deformities, and so on. Trauma heals. We don't have to make a big fuss. All of us have had wounds and they've healed despite the messing around that goes on. Acute wounds heal. They are programmed to heal, and from medical student days we've been told it's these phases, one after the other. There is some overlap, but it heals. So the problem is when there is contamination with bacteria, or the quantity of injury and tissue depth is excessive, and bacteria kills host tissue, it stops healing via the products. And acute wound infection is a clinical diagnosis. It's another thing. And that's when the wound doesn't progress towards healing and we get stuck in the inflammatory phase. And there is a lot of inflammation, little proliferation, and the wound either stays static or gets worse. Antibiotics, debridement, and drainage, it actually assists to clear the mess. That's what inflammation does. It clears and prepares the wound to heal. So what we do is get on side of the patient, give antibiotics, debride and drain as Dr. Ranjuka demonstrated in a lot of pictures, and we assist in the natural clearing process and prepare the wound to heal. Just one set of feet. You can see the acute inflammation clinically diagnosed. Finger pressure will demonstrate extension of the sepsis along the tendon sheath, and then we need to, the principle is to drain it and excise what is necrotic. Here you see on the right, and you see the pus, and we need to incise and excise up to the whole red area and make sure that all the pus is drained by applying digital pressure. And under debridement or delay is one of the chief problems that keeps the process going on and on. The picture on your right shows quite a bit of spread and complete debridement right down to red tissue. Nothing yellow, nothing gray, nothing black should remain. Right. Now, what's a chronic wound? We need to understand the difference. How do we know it's chronic? That is only when wounds do not progress towards closure at a consistent rate. Either it has to close by 50% in 4 weeks or 10 to 15% every week. And if that is the natural, successful healing rate. Now, if it doesn't happen, whether it's a diabetic foot or any other ulcer, then it is chronic. There is a problem. There is a problem. And the commonest reason is infection, but we know how to treat infection with antibiotics based on antibiotic sensitivity and removing necrotic tissue. In the absence of infection, we often see wounds that don't progress towards healing in the expected way. Now, that's when there is chronic inflammation. There is chronic inflammation, and it may not be obvious. It's not clinically obvious, apart from the wound not healing. So coming to chronic wound care, it's very popular, this T.I.M.E concept. D for drainage, earlier it was time, tissue, same thing. Inflammation, infection is I, moisture balance is M, and edge management is E. And I think Dr. Thushan is going to deal with with it in the next lecture. So I'm going to concentrate, I've been given the task of dealing with D, debridement. So how do wounds heal? We need to heal them, and we need to heal fast. Back to the original wound phases, and here we find that the natural process of clearing and prepping fails, and there is, due to continued or excessive injury. Either it's traumatic, repetitive trauma from neuropathy, or it's microbial or ischemic, or an immune problem. But the trauma, the injury goes on. And that gives rise to either grossly infected and necrotic tissue. In addition, there is biofilm, metalloproteinases on the wound base, and senescent cells in the wound edge. All these things will develop with time, and then it sabotages healing. Let me repeat, the biofilm, the metalloproteinases that come from infection, but even from non-infective cells, which are on the wound base, and the senescent cells at the edge. The fibroblasts completely change its appearance and function, and starts producing stuff like what bacteria do, giving rise to a very hostile environment. That's the hostile environment. And debridement is removing all the matter, not all the factors. Factors are there. But we are talking about the stuff in the wound that is preventing the healing. So we need to understand that all infection results in inflammation, but all inflammation is not necessarily associated with infection. Right? And all chronic wounds are colonized. And over 60% have been estimated on electron microscopy to have biofilms. And critical colonization going on to invasion, invasive infection, is what we can recognize from the appearance of the wound and the other clinical features. So, when there is peri-wound redness, it's not always infective. It can be just chronic inflammation without infection. But in the real world, there is a combination. It's both. And we tend to focus on the infective part and ignore the non-infective chronic inflammatory process. So, let me reiterate, the hostile environment from necrotic or foreign material senescent cells and biofilm bacteria produce the metalloproteinases, and also irreversibly alters the fibroblasts in appearance and function, both. It destroys the chemotactic factors, the growth factors that are very necessary for the proliferative process. And it consumes local resources as well, this necrotic material and the bacteria, the oxygen, nutrition, and the building blocks, and enables bacteria to proliferate, and therefore, by itself, without without additional colonization, the existing bacteria multiply, and you get critical colonization going on to infection. So, just like we talk of critical colonization of bacteria, there is also, we can think of senescent cells and biofilm having a critical mass. So, in the absence of infection, the senescent cells and the biofilm can keep the wound going. So, however much you try to give antibiotics, we see patients being killed with antibiotics, wounds don't heal. So, just to remind ourselves of the biofilm idea, it's a polymicrobial sessile community of phenotypically altered microorganisms, and these microbes alter their metabolic function, lower it, and they can survive with hardly anything. And they become very resistant to all the antimicrobials we put on wounds, as well as antibiotics. And they do their work, that is sabotaging the healing process. Quorum sensing is the process by which cells are phenotypically altered and downregulated in their cellular activity. Okay, so what about debridement? How do we do that? Surgeons, for good reason, do sharp surgical debridement and complete removal of necrotic material, everything, the matters that hinders wound healing is our target. But we need to preserve healthy tissue. We need to think of healing at the end of this. So you mustn't overdo it, but underdoing it is as bad. We should avoid diathermy because it causes more necrotic tissue. We should not mass ligate bleeding points. It's best to put topical agents and put compression for hemostasis, provided the perfusion is okay. Tangential excision with a sharp blade. Remember that our scalpels blunt very quickly, even during the process. Sharp, new blades are very important. I know hospitals give you blunt scissors, which crushes the tissues, and it's not recommended. You need sharp, well-cutting instruments. So you have the forceps, and if you have these, the Mackindos, you usually hold with the Mackindo the stuff that you're going to remove, not what you're going to leave behind, in order to minimize any physical trauma in the tissue that you leave behind. And the bone nibblers. I'm sure we're all very familiar with this stuff. Now, so what you debride is to convert the chronic to an acute wound. Because it's an acute wound, it's the acute stuff that heals. We need to change the chronic to acute. How do we do that? So here is a picture of a chronic, it's a non-infected venous stasis wound. We see lots of these. We need to debride this thoroughly, completely. So one trick is to use methylene blue. I mean, I personally do it infrequently, but I think after having read more about this recently, I probably should use more of it to paint it and cut it out so that none of the blue remains. And this includes about 2-3 millimeters beyond the edge where the senescent cells are. You cannot recognize their presence macroscopically. Neither can you recognize biofilm. Most of the time it's not recognizable separately. These are some of the similar ones to what Dr. Ranjuka showed. When you debride sharp, you need to get rid of all but the red tissue. All the black, all the yellow, all the brown must go. And you need to put digital pressure on the edge to make sure that no purulent exudate or pus comes into the wound, because that shows under the skin there is necrotic infected material. Non-infective erythema is also happens in ischemic wounds. The dependent hyperemia might trick you into believing there's infection, and one needs to be guarded about that, because what you need to do for that is revascularize. There is no acute inflammation, just redness, and the redness disappears when you elevate the foot. How else can we debride? More recently, hydrosurgical debriders have come into, are available in practice. Ideal for biofilm removal. It can cut less than 1 millimeter thickness tissue. We don't have this. We have had demonstrations, equipment brought here, but it's really too expensive for, definitely not for the public sector. Even the private sector, it's very expensive because you need to keep using it over and over again. It also removes the debris. Cost is the problem. What about ischemic wounds? If there's active infection, you need to debride without delay. It's very difficult to see normal from abnormal tissue when there is severe ischemia, and you might overdo it. So it's a question of judgment. You don't want to remove too much because you need to heal the foot, preserve the foot. You don't want to underdo it so that the problem just continues. That's tough. Wounds that are not infected or there is dry gangrene, revascularization must precede. You don't need to debride. You give it a few days, maybe 4 to 8 days after revascularizing, and then you will get a clear demarcation between what is good and bad, and then you can debride. After endovascular surgery, you need to give more time because it is never as good reperfusion as after a bypass operation. So that would be the contraindication for debridement, dry necrosis. Dry necrosis doesn't need debridement. It can heal under the necrotic tissue, and you just need to monitor that there is no infection during this process. So what about non-surgical techniques? Sharp surgical debridement, the problem is the pain, but not in diabetics. Most diabetics are anesthetic feet. So I think we should not worry about pain. Is not an issue. You can debride them in the outpatients or even in the hospital without waiting for an anesthetist. But all the other ulcers are extremely painful, and you need anesthesia, and the cost, admission costs, is the issue. What about the old-fashioned wet to dry dressings, where the dressing dries up, the whole thing dries up, and the necrotic tissue adheres to the gauze? When you pull it off, you get debridement, but it's painful and it traumatizes the underlying healthy tissue. Autolytic hydrogels are very popular, and then it facilitates separation of good from bad, and you can do an easy, sharp separation, but it takes time. Enzymatic debridement is very popular for the same reason. It does the job quicker. Maggots, in the literature, it's very effective. Maggots eat up the necrotic material, it eats up the bacteria, and it produces stuff, the growth factors that accelerate wound healing. There are a few studies that have shown that maggot therapy heals faster than the other non-surgical debridement techniques. And once again, the cost and acceptability of maggots is a bit of an issue. People don't like, unless we put maggots without telling people, but that's not possible. It has to be acceptable. Then we have non-contact low-frequency ultrasound therapy, non-contact, and a lot of research has shown that in addition to separation of what you don't want from the wound, it also stimulates the host tissue, pushes it towards healing by doing the necessary changes to the cell function. So it's a critical step. Debridement is a critical step in the transition of a chronic wound into an acute one. We must not forget the other factors. It must be optimized. Sugar control, nutritional status, smoking must stop, vasculature must be regulated, and peri-wound edema has to be controlled with either rest or compression. And all the other potential causes must not be forgotten. The pathophysiology of wound chronicity in the absence of infection, the irreversible development of senescent cells around the wound edge, and biofilm on the wound base should never be overlooked. And we need to suspect these factors when the wounds don't progress despite the absence of infection. Yeah, this is clearly a neuropathic, not infected, a lot of callus. This goes on and on. Yeah, repetitive trauma is the problem, but you can see a lot of senescent cells there, which maintains a very hostile environment for wound closure. And it's a simple procedure to remove the edge and offload, and you get healing. So I'll leave you with that. Thanks.
Thank you. Next, to talk about timely ulcer care, Dr. Thushan Gooneratne, who is a consultant vascular and transplant surgeon and a senior lecturer at the surgical professorial unit of Faculty of Medicine, University of Colombo.
Thank you, Chairperson, sir, for the introduction. So thank you for the opportunity to speak. We're going to talk about timely ulcer care. It's within some the brackets, and there's some abbreviations also. I'm sure it will make sense as we go along as to why it's mentioned in that fashion. So we'll talk about how to manage the ulcer. I think the components of things beforehand has already been spoken by the speakers before me. So as we all know, the whole idea behind this is to heal the wound as fast as possible, find the most efficient, most feasible, most cost-effective, harmless way of getting to this point. And as Prof. Mandika told you, chronic wounds is a problem because it has stopped at some point in this trajectory, commonly the inflammatory phase, sometimes proliferation for various reasons, and the idea is to get it back onto this healing trajectory, either from the beginning or to continue from there onwards. So most of us feel wound care or the ulcer care is about dressings, and in fact, it's probably the worst or the far from it. It's not about wound dressings. It's also not about caring of the wound. The ulcer care that we're going to talk about and we want to do is about caring of the person with the chronic wound. And there's a big difference in how you approach it if you look at this problem in that sense. So as a famous saying, look at the whole patient and not just the hole in the patient. So how do we get to this point? This is what we have. We need to somehow get to this point. In essence, it's about making sure you put all the good things in, put all the friendly factors, remove all negative factors, and then you try and heal and get that wound bed prepared while this is happening. And of course, there are a lot of things that adjuncts to this problem that need to be sorted out to try and make sure the patient also gets to the end of this program. So this is what we want to achieve. As already explained, I think you cannot highlight it more and cannot stress it enough. You've got to find the primary cause, first of all, if it is there. Any given wound, I say any, I think 100% is not achievable, but most wounds will heal, and they'll only heal if you make sure the primary causes have been addressed. And in our practice, we talk about the VIPs, and at least it helps to realize that you cannot forget these three things, the vasculopathy, the infection, the immunopathy, the pressure and the injury and the neuropathy that comes with it. And that needs to be sorted out. Otherwise, no matter what dressings you put, how much of time and money and space you spend on the wound, it will not heal. The sad or the difficult part is it doesn't come with a label saying this is what you have. Sometimes it's very clear, sometimes it's not. And that's where your skills as a trainee, as a consultant, with experience, you'll realize you've got to look at lots of different things, try and figure out what those primary things are. Of course, so as already spoken about this, sometimes it's very clear there's arterial assessment going on, there's an arterial problem happening. Sometimes venous, can be superficial, can be deep. Sometimes lymphatic, a bit different from venous. Sometimes it's a combination. You find diabetic foot having swelling as well, and how do you manage that then? And of course, the age-old problem of neuropathy, and the whole spectrum of neuropathy that I was already spoken to you about. But you need to look for these things, and once you do find them, you sort them out, either yourselves or you send them to the right people to do that business. And I'm going to talk about 3 assessments and 3 goals of this ulcer care, and that primarily is the first step in this business. You cannot look at the wound, cannot start treating the wound unless you get the primary causes sorted out. The second thing I would like to mention, and the second goal, is you all forget, and this is about the whole patient as well, you got to look at these things as well. And unless these are sorted out, you will not be able to achieve the end point and the end goal. So whether it's diabetes, it's nutrition, your anemia, your poor mobility, your social factors, your mental health, spiritual factors, whatever is required to get to the patient as a whole, sort them out, and that for me is a second priority before we even touch the wound and get to the wound dressings itself. So assuming that these have been sorted out, let's get back to the business of the timely ulcer care. And if you feel this wound is salvageable and you can achieve healing and it's going to be what is going to achieve the quality of life to this patient, then let's get on to try and get to the third goal, and that's trying to prepare the wound. Now, we talk about wound bed. There's a bit of difference that's going on now. We talk about this triangle of wound assessment, and all this is something we're already very aware about, but just putting into perspective. The wound bed is only a part of it. Do not forget the wound edge, and do not forget the peri-wound skin, which often get ignored. So let me concentrate on the wound bed as the most important thing, and we talk a little bit about the edge. Prof has already spoken a little bit about it as well. as the saying goes, time doesn't heal all wounds. In wound care, you look at this time concept to try and get to that point. And it's a very old thing, 2003, so 2 decades old. It has evolved, and I'll explain a little bit about it at the end. But essentially, it talks about the simple, straightforward things, and these are the primary things. So when we look at a wound, we try and look at a wound, the chronic ulcer, in this sort of concept. How to get these things sorted out. The tissue management, and that for me is about just this wound requires the debridement Prof. Mandika was talking about. Does it need that to be happen? Eye infection, is there inflammation? Or is there inflammation and infection? Does it need to be kept under control? We like to have a moist wound bed. It's about moist wound healing nowadays. We have gone beyond the wet to dry. You look at moist wound healing, how to get a moist wound bed. And it's the wound epithelializing, the E. And let's get back to how these are going to work out. So, a little bit about tissue. And we've already seen lots of pictures and talk about how colors are there. If you want to keep it very simple, think of 4 colors. And these are the 4 colors you normally would see in different spectrum of a different variety, right? And black is necrotic tissue often. The yellow tends to be slough. You see the red color, the granulation tissue, and you see pink epithelial tissue. What we want to see more and more is less and less black, less and less yellow, more and more red. If you have lots of red, it will gradually turn pink, hopefully, and close off. So, debridement is what Prof talked about, that wound edge or the biofilm or the wound surface or the tissue is about getting rid of those bad stuff and getting a wound bed that will generally start to get into a healing process. Won't spend much of time, we've already spoken about it, but there are different ways of doing this. The top 2 tends to be more science behind it in terms of technical aspects going on. But you also realize that most of this debridement can also be done with dressings. And that's how a lot of the pharma industry in dressings talk about debridement using dressings as well. This is the surgical debridement that I was already spoken to you about. Skip that the section, and I'm sure you have a lot of information on it already. There are mechanical debridements that can be done and uses either water or ultrasound. They are available in Sri Lanka. They are common and shown the products, not often used in practice. But sometimes you don't need the sharp debridement. You don't need to cut it physically and remove all bad tissue, because as you do that, you are invariably going to damage some healthy tissue as well. So you can use dressings perhaps, or sometimes remove only the bad stuff and leave the good stuff behind. It's a little bit slower, a little bit more painstaking, but it is also very useful and something to think about. So you can use dressings in terms of autolysis. This is moist wound healing. Have a moist wound bed that will help the yellow stuff to become more liquefied, and it will get onto the dressing, and it will come off with the dressing gradually with time. Biological debridement with maggots, especially useful for bad wounds, a lot of tissue. You can't get into those spaces. They are creeping under granulation tissue, tendon tracts, tendon pathways, often used for deep wounds. And this enzymatic debridement, now a lot of products are available. The time of using papa or raw papa and cutting the skin off and rubbing and mushing it and putting on a wound is gone. You can have commercial papain products now in the market. There are plenty of them available, and they have their own benefits. So it's not the place to talk about how and why you might use one of them, but essentially is understanding that if you have those bad colors, you got to get rid of them. You have various options of doing that. You need to figure out what is going to work best in your resources, in the facility you have, with the finances you have, in the capacity you have, and the time frame you have. They all are useful in their own ways. Okay, so I'll move on to eye, and that's the inflammation, infection going on. We like doing wound swabs, and I think just to take some key points, every wound swab is going to grow an organism. It's going to happen. Because there is always going to be contamination. If there's a wound exposed, there's got to be bugs in it. But what you want is to get to that red guys. That's a danger area where the wound infection or the wound bugs have grown to a point where they're going to cause host tissue damage. And that phase of infection, it could be a small critical colonization, not very clear as to where exactly that is and how to figure out that point clearly. Talk about biofilm at that point as well, as to this transition between a a colonized wound to an infected wound, but then you know when the wound is infected. Unfortunately, in diabetes, it is not so straightforward, like already spoken to by the two speakers. It's all hidden, it's missed, it's not clear in the same, so you don't find the classic symptoms. So, especially in diabetes, you need to be very vigilant, very careful to try and not miss, because it could be the next visit. By the time the next visit comes, they lost most of the foot and you will have lost the chance of a limb salvage. How would you be able to pick this up? And Buddhima would talk about these red flag signs also. There are various criteria, no point going too much into depths of these, but they do talk about common things. Sometimes it's a superficial infection, sometimes a deep infection. Deep infection could be deep tissue, could be subfascial, sometimes bones and joints. So you've got to use various methods to try and figure it out. Often, if you listen to the patient might themselves say, this time the wound is too exudative, this time the wound is too smelly, it's not looking good this time. And patient might be actually telling you, look, this is the early sign of infection happening, before you see the redness or the pain or the pus discharge coming through. So be vigilant about these things and try and make sure you pick it up early. Again, the IDSA is the current guidelines if you want to really look into more science behind it, but they do talk about the same sort of things. And if you think of the basic concepts of infection, looking for the early signs of infection, you should pick it up and then manage it accordingly. And this is deep infection, very minuscule looking small wound, but it's gone well beyond that. So we know in infection that all wounds are contaminated. What we want is to get to that wounds that have a high level, because they will cause detrimental issues. How do we do it? You can treat it either with debridement, so remove it and cut it off completely, but sometimes you got to treat the bug as well. If it's systemic, you might want to give systemic antibiotics. Some people do give topical antibiotics as well. The whole problem with antibiotics is it's going to cause resistance. And that's why the market and the industry and the dressings are promoting antimicrobial dressings rather than antibacterial products, with the hope that it would reduce resistance development, right, and less hypersensitivity. And sometimes you use this with other factors to make a better outcome. Silver and iodine remain the more prominent players in the market, but doesn't mean acetic acid or betadine or hydrogen peroxide or hypertonic saline or Milton's, whatever you want to use, is not effective. As long as you use it judicially and carefully, these can be used with its own caveats of use. Silver and iodine are considered two products that do not develop resistance and can be used even for MDR bugs. There's a lot of interest in PHMB. This is something that Prof talked about in terms of biofilm. It will help to get rid of that senescent cells, or that top layer of useless guys preventing us from getting to the wound bed. And these could be either cleansing agents or gel agents. So some things to just have a look and think about. So I won't talk about much, but hopefully it will stimulate you to answer yourself some questions when you would actually start collecting samples, and what sample you want to do. Would you do for wound swabs? We like to go for tissue samples if possible. Our go-to would be a tissue sample that has been cleaned already. So clean the wound bed in theater perhaps and get a good tissue sample that you think is representative of the bug in the wound. Think of the biofilm if you want to. The Prof has already spoken about it. Okay, so last few bits. So if you've done the T and the I, then you're left with, so hopefully you've done the debridement, you've got the bugs and things sorted out. It's about getting onto the moisture level and getting a moist wound bed. Like in most cases, in anything in life, you need to have the right balance of things. You don't want somebody too dry, and you don't want somebody too wet. And the same goes to the wound, because the wound is also having cells in it. The cells require the right moisture balance. If you don't have the right moisture balance, it is going to cause harm. With whatever form is going to happen, either by desiccation or by maceration, you're going to have slower wound healing. We also got to remember, we want to have moist wound healing, but this moisture changes with time. As the wound progresses, it might get a different moisture level, and you got to change the way you practice, the way you use your dressings to adapt to it as well. You might the wound going from one end to another end, and the various dressings that are available in the market are targeted to match those wound moisture levels. So if it's very dry, you might want to use a certain type of wound dressings like gels that do tend to donate some fluid. You can want to have a transparent film to keep the wound moisture trapped. And as you go along more moisture levels, you want to have dressings that absorb it. Not the place to talk about dressings itself and the various types of dressings, but I hope we will figure out that you need to try and use the right form of dressings for the right wound and change accordingly as the wound changes. The good thing about dressings, they do tend to allow you to combine things. You can combine debridement, you can combine infection, you can combine moisture, and do various funny things, and the market has grown to allow you to do that. You can have a foam with infection, you can have a gel without infection, you can have a gel with silver. So a lot of things can be done, but remember, a lot of things are there market. You decide based on what you have, based on cost, and all those things, what is going to work best for your patient. Because end of the day, is getting that basic aim of holistic care sorted out. Wound edge, again, Prof has already spoken about, you want the epithelium to come and clean the wound and sort it out. You don't want this is undermined wound, and you got lots of this stuff happening around. Neither do you want this at the other extreme of callus and hyperkeratotic wounds. That's not going to close in. Time has changed to timer and timers, and R is about repair and regeneration. And if you might want to think of regenerating the tissue, it could be using vacuum dressings, it could be using growth factors, it could be using various stem cells, PRPs, whatever you want to use. The market is there now, it's getting more and more productive in terms of reconstruction and regeneration to try and get that wound to final wound healing. So for me, assessment 3, and that's the last goal we talk about, is to make sure you have the right wound bed, right wound edge, and the right peri-wound skin, and you should be able to achieve wound healing. A couple of minutes on what's going on. Technology is developed. We are looking at more targeted therapy of wound care, getting samples of the wound and thinking, look, this is the right dressing you need for this particular type of wound. And AI is taking a huge market in trying to design and develop personalized wound dressings for each wound. These are all in molecular is available, looking for point of care testing of infection. Sonar waves are there for debridement, but need to remind ourselves that as much as a lot of fancy stuff are happening, you got to get to the basic and the priorities. And for me, it's about making sure ischemia, if it's there, has been sorted out. Either by open intervention or by endovascular intervention, get that wound sorted out. If it is venous, you got to sort that out. In an era of endovascular intervention, you got to be doing endovenous interventions and getting your deep veins and superficial veins sorted out. If swelling, compressed, if it's lymphedema, sort it out. You need to get those basic stuff sorted out. And as Dr. Ranjuka also mentioned earlier, looking at dressings, if it's neuropathy, you got to find the right way of offloading it. It is basic stuff, and that is easy for the patient. Sometimes you need to go into more high-end stuff which require a bit more complex work to heal difficult wounds. And you need to get this done, and you need to balance out your VIPs to balance out your time factor and your time of ulcer healing. Get the wound edge, get the peri-wound skin sorted out. Think of the social factors that are essential in current wound care and current management of patients. They lose their lives, they lose their money, they lose their vehicles and their land, try and save a wound, save a leg. But it's what they want, and if that is the case, that's fine, but you shouldn't necessarily push somebody into that position. Look at the patient, get the holistic wound care. One little bit, it's a lot of work required for this, whether it's microbial, whether it's diagnostic, whether it is surgical, whether it is the lab or the bench. You can't do it alone. It requires a team to get this timely ulcer care sorted out. And only then would you be able to prevent this from happening. Bad debridements, bad wound care, and get more of these, more salvaged tissue, and more people saved and more limbs saved. And hopefully have a smiling patient who's happier then with what you have done. And thank you for your kind attention, and hope that was of some use. Thanks.
Thank you, Thushan. The last speaker is Dr. Buddhima Jayawickrama. She is a consultant vascular and transplant surgeon from National Hospital, Kandy.
Good morning. This is the last lecture of the symposium, and I won't take much time because it's basically like the summary of what has already been spoken. As told before, neuropathy, ischemia, and neuroischemia being the major causes of foot ulceration in diabetics, and with superadded infection, it becomes the major cause of morbidity and mortality in diabetic patients. So, red flags, basically, I will just concentrate on infection and ischemia, because these are the two factors that can either lose the limb of the patient or the life of the patient. But they don't actually present as red flags itself, because these patients, they have neuropathy, and most of their collections and abscesses and infection are hidden within the soles. Unless you particularly look for that, you won't find them. And infection, they do not present with overt sepsis, or most of the time not even features of any features of sepsis, because they have very poor immune response, and it's just for you to just look and find out that these guys are in danger. And ischemia is often overlooked, because people tend to think of ischemia when the wound doesn't heal even after repeated debridement. So that's the usual place that people think, oh, this is not healing, can this be ischemic, right? So this is why we miss. This is why they become the red flags. So, neuropathy and diabetic foot infection. So, this is a sole of a patient who came to our routine clinic follow-up after a bypass of the contralateral limb. As a routine, we check the feet and the sole, and then this is one of my medical officers found that this patient had a collection on the other side, not the side that we are concerned, right? He just came walking into the clinic. So, if not seen, if not you particularly look at it, this would be easily missed. This is another thing, you only see, if you just look from the front, it would be that gangrenous toe. But if you look at the sole only, you see that it is spreading along the tendon, along the sole. Similarly, you see, now you just see that wound, but if you actually debride, you see how much infected and inflamed tissue that has been there within. Similarly, neuropathy. So, this one, now, if you just see from front, it's just a simple ulcer. You actually hardly see anything on it. But only if you press that you will see, I don't know whether you can see, there's pus inside, right? Because it's just usually thought, it's just a simple wound, and just send some and give some antibiotics and it will settle. But it's not. Unless you press and see, you won't see it. Similar one here. Now you see like an abscess over the dorsum of the foot, but the extension is hidden within. You have to press along the tendon and see to which extent that it goes. So, again, now here we see just multiple openings, but if you actually remove it, you can see how much that infection and inflammation has been within. So, if it is non-ischemic, we remove, this has been already told, as I told before, non-ischemic, we remove all infected necrotic tissue and exposed tendons. So, then the other thing, diabetic foot ulcers and ischemia. That is the other red flag, ischemia, to identify ischemia. So, you see a dry gangrene, you have to think of ischemia. When you see multiple gangrenous toes, blackish tissues, non-healing, desiccated tissues, you have to always suspect ischemia. Even now, this is how we get, like after repeated debridement, non-healing ulcers. So, you have to always suspect ischemia, check pulse, and then we have to revascularize. Then again, ischemic and infected. When there's ischemia, and top of that, there's infection as well. You can see these gangrenous toes and the infection spreading. So, in those cases, what we do, we convert the non-infected wound to a non-infected ischemic wound, we revascularize, and then we do the complete debridement. So in summary, diabetic foot ulcers, red flags, are most of the time not that evident unless you look for them. So we have to recognize ischemia, always check pulses before debridement, always recognize infection, always look at the soles and press along the tendons and elicit the infections. Otherwise, you will miss them. Thank you.
Thank you very much, madam. Ladies and gentlemen, that concludes the Vascular Symposium on Diabetic Foot Diseases. I cordially invite the chairpersons, Professor Resni Kasim and Professor Bandula Samrasinghe, to award the certificates and tokens of appreciation to the resource persons. Dr. Ranjuka Ubayasiri, Professor Mandika Wijeyaratne, Dr. Thushan Gooneratne, Dr. Buddhima Jayawickrama. Dr. Buddhima Jayawickrama. Thank you, sirs. To thank our chairpersons for their invaluable contribution, I invite Dr. Roshan Dasanayake, President, Association of General Surgeons of Sri Lanka, to award the certificates of appreciation to our chairpersons. Professor Resni Kasim, Professor Bandula Samrasinghe. Thank you, sir. Moving on to Symposium 4, renal stones are a common urological problem with significant health implications, ranging from pain to infections. This symposium will cover the latest in minimally invasive treatment methods and preventive strategies. To chair this session, I respectfully invite Professor A.U.B. Pethiyagoda, Professor in Urology and Consultant Urological Surgeon, Faculty of Medicine, University of Peradeniya, and Dr. Ranga Vikramarachchi, Consultant Urological Surgeon. Over to you, sirs.
Thank you very much. Good morning to everybody. To start proceedings, I would invite our first speaker, Dr. Manjula Herath, Consultant Urological Surgeon, National Hospital, Kandy.
Good morning, ladies and gentlemen. Frontiers of minimal invasive stone management. And where we are. The world's first telephone patent was awarded to Alexander Graham Bell, and its main purpose was to make calls. But later mobile phones were developed to perform many functions using different operative system, though their ultimate goal remains same. In very similar manner, open stone surgery were transformed into minimal invasive procedures, using various operative techniques as in mobile phones to achieve similar endpoint. The prevalence of stone disease has been reported up to 20%, and it is underreported in Asia Sri Lanka region. It accounts for 3.2% of end-stage kidney disease. Approximately 25% develop recurrent disease within next 5 years, which account for losing working hours as well as frequent hospitalization and burden to economy. History of stone surgery goes back to pre-anesthetic era, where they perform lithotomy to remove bladder stones. With the development of anesthesia, open surgery became more popular. Since 1960, various new minimal invasive techniques were developed, including ESWL, PCNL, ureteroscopy, laparoscopy, and robotics. Major pitfall of open surgeries are major collateral tissue injury, prolonged hospitalization and delayed recovery, and difficulties associated with redo surgery, especially renal surgeries. So what are the key milestones of minimal invasive surgery? Endoscopy, stone breaking system, development of accessory devices, real-time imaging techniques, and laparoscopy and robotics. Both rod lens and fiber optic telescopes has revolutionized minimally invasive surgery. Current HD system give a better clarity than our naked eye and more precise vision. Both ultrasound scan and fluoroscopy were the turning point in upper tract endourology to get guided access. Many stone breaking mechanisms have been developed. Currently, shock waves, pneumatic and laser lithotripsy play a pivotal role. To remove these fragmented stones, various trapping devices and baskets were developed. You can see in this picture how they retrieve the stone in the ureter. Other than that, there are many accessory devices were developed, including flexible access sheath to access the lower calyx, balloon dilators for PCNL, and different sheath and guide wires. So now we have many methods and different access mode to achieve same target. ESW is an OPD procedure that typically require no anesthesia except for kids. It is most suitable for non-lower pole stone less than 2 cm and selected lower pole stone less than 1 cm, as well as upper ureteric stones. Semi-rigid and flexible ureteroscopy are used commonly in retrograde manner to access all areas of the genitourinary tract. With the laser, you can break the stone into smaller pieces and retrieve. Recently, disposable flexible ureteroscope came to the market with greater flexibility, smaller in size, improved imaging quality, and low maintenance costs compared with the standard ureteroscope, and integrated suction irrigation system. PCNL is the standard procedure for the renal stone larger than 2 cm in size. Initially performed in the prone position, but now PCNL is more commonly done in the supine position. Moving from fluoroscopy to ultrasound guide has also helped to reduce the risk of radiation exposure, especially surgical team. Similar to RIRS, it is now also possible to achieve miniaturization of the nephroscope. Currently, micro PCNL instrument size is 4.8 French. Additionally, flexible nephroscope allow us to avoid multiple punctures, especially in complex renal stones. This was done, this was one of our 18-year-old pediatric PCNL. Complete clearance achieved in 4 sessions using mini PCNL technique. The technique is standard for pediatric surgery, quick recovery and short hospital stay. Mini PCNL is not always the best option. You can see the stone there. We were able to complete in 1 puncture and 1 frag. Similar to Android and iOS, there is ongoing competition developed between RIRS and PCNL. But on the other hand, competition is not always the best approach. Many hybrid procedures now develop. You can see here supine PCNL and flexible URS to achieve good clearance. Here one of our case. One of our case we did laparoscopy assisted PCNL for a pelvic kidney with stones. Sorry. Yeah, this is a laparoscopic assisted PCNL for a pelvic kidney with the stones. And laparoscopy assistance is important with pelvic kidney, retrocolon, horseshoe kidneys, low, and it has low morbidity and compared to open surgery. Robotic has now entered the field. Here you can see how RIRS is performed using robotic assistant. Currently it is dream for us, but future it will be available for us as well. So what are the challenges do we face in Sri Lanka? Technical challenges with instrument, patient-specific factors, cost of the instrument and availability, and expertise and workload, especially stone burden in Sri Lanka. In summary, ESW has a low stone-free rate compared to RIRS. ESW has higher retreatment rate versus URS and PCNL. PCNL has higher stone-free rate compared to both other procedure. PCNL has higher complication rate compared to other two. So complication rate highest in PCNL, then URS, and lowest in ESWL. And regarding ureteric stones, upper ureteric stones more than 1 centimeter better to manage with URS or antegrade URS compared to ESWL. But when the stone size is less than 1 centimeter, for upper ureteric stone, ESWL is better, but you have to get the patient what he really want. And low ureteric stones, better to go for URS compared with ESWL. But it's an individual decision after this discussion with patient. Then considering renal stones, important factors are stone location, size, composition, anatomy, body habitus, etc. And PCNL is more suitable for stone more than 2 centimeter and stone in between 10 to 20 millimeter. ESW also suitable, and also you can consider other two procedures. And stone less than 10 millimeter, all three procedures you can consider. Especially you can consider for mini PCNL and micro PCNL. So instruments have progressed from macro to mini and micro. Advanced stone breaking systems such as holmium and thulium laser play a pivotal role in minimal access surgery now. Robotic surgery already in the practice, and AI is anticipated to play a significant role in future. Thank you very much.
Thank you, Dr. Herath. With the time constraints, we'll leave the questions to the end and we'll move on with the next one. Our next speaker is Dr. Thaha M Musthafa. Thaha is a consultant neurological surgeon from Teaching Hospital Badulla. He is going to focus on emergencies in urolithiasis. Over to you, Thaha.
Good morning, everyone. Should like to thank College of Surgeons for giving this opportunity to talk on this topic, emergencies in urolithiasis. As we all know, most of the workload done by a general urologist is due to stones, and considerable amount of these patients are ended up in casualty ward due to emergencies of urolithiasis. Things we are going to discuss is okay, we are going to discuss the emergencies in urolithiasis. Number one is intractable pain. Number two, obstructive uropathy, which is causing nephropathy. And mostly we are going to focus on infected obstructed kidneys, and then urethral stone, which is causing acute urinary retention. As we all know, all the emergencies in urolithiasis is purely due to obstruction of the urinary flow. Bit of terminology, obstructive uropathy is the anatomical of, is there is a blockage of the urinary flow, whether it is structural or functional, and the renal parenchymal disease caused by obstruction is called nephropathy. And obstructive uropathy is responsible for more than 10% of patients who are having acute or chronic kidney disease, and 2% of patients who end up in chronic hemodialysis. What is happening in ureteric obstruction? So first we'll talk about unilateral ureteric obstruction. It's a triphasic phenomenon. These studies have been done in animals, mostly rat and dogs. Phase 1, there is pre-glomerular vasodilatation. It will be there for up to 90 minutes, and from 90 minutes to 5 hours, there will be post-glomerular vasoconstriction, and after that, there will be pre- and post-glomerular vasoconstriction. Because of this, there is reduced blood flow to the single nephron, and there is shunting of blood from the outer cortex to the inner cortex, and because of that, there is reduction of renal blood flow occurs. This has been depicted in this graph, where you can appreciate this time duration and the rise of ureteric pressure and reduction in the renal blood flow. What happens is bilateral ureteric obstruction, or obstruction in a solitary functioning kidney or a single kidney. Only two-phasic, this is biphasic obstruction, and there is slight rise in the renal blood flow. It is transient due to preglomerular vasodilatation, and later on it will be vasoconstriction post and pre. When there is ongoing obstruction, if the obstruction is not relieved, there will be damage to the tubules because of ischemia due to reduced renal blood flow, and that damaged tubular cells will secrete pro-fibrotic inflammatory markers and cytokines, which will end up in fibrosis, end-stage renal failure. Here we have to address in initial stage to prevent kidney loss. This is the diagram where, if you wait for months, weeks to months, there will be fibrosis of the parenchyma. This terminology is important. So why we are not seeing calicial rupture in acute onset of ureteric obstruction? This is due to pyelointerstitial backflow. There is a backflow of urine into the interstitium, which is drained by the lymphatic, but it will not last longer. The initial stage, it will happen, but later on, we may see calicial rupture and perinephritic fluid. When the obstruction is released, even though the obstruction is released, the concentrating ability of the kidney may be lost. So kidney may be losing certain amount of fluid and water, which will cause post-obstructive diuresis. Mostly 2% of the patient with unilateral obstruction, we can see that, and almost 50% of the patient with bilateral obstruction or obstruction in a single kidney, we will appreciate this condition. Post-obstructive diuresis is more than 200 milliliter for the first hour, or the urine output is more than 3 liters per 24 hours. So let's talk about the emergencies in urolithiasis. Number one is intractable pain. It is due to, we know that to have a peristalsis or colicky pain, the organ should be a hollow viscous and it should have a muscular wall. So the ureteric colic is due to stretching or the peristalsis, but the renal pain is due to stretching of the capsule. Initially, the renal blood flow is increased, so there is ongoing production of urine, and there is peristalsis or contraction of ureteric muscle, which will cause more pain. And it is seen in the ultrasound scan as hydronephrosis due to compensatory hypertrophy of smooth muscles. How are you going to treat this? Whether NSAIDs or opioids? So studies have shown there's no difference between opioids and NSAIDs. But if you treat with NSAIDs, side effects are less. Number two, we should not need any rescue analgesia. So why the reason is, we know from our physiology or pharmacology, the NSAIDs act on cyclooxygenase pathway, and it inhibits metabolites or production of metabolites of arachidonic acid. Arachidonic acid metabolites are inflammatory markers or the inflammatory mediators, and if there is reduction of those metabolites, pain receptor activity will be less, and there will be reduction of peristalsis also, which will subside the pain. But caution, we should always consider the renal function. If the renal function is high, there we should not use NSAIDs. What the guideline says, EA guidelines, strong recommendation to use NSAIDs, weak recommendation to use opioids, and if the pain is not responding to both, we need to address the stone, either decompression or ureteroscopic or stone removal. And this is the area we have concentrated more infected, obstructed kidneys. The kidneys are crying because they are blocked, they can't drain the urine, and it is a neurological emergency. And you can appreciate that urosepsis is responsible for 20 to 30% of all the septic patients, and 40% or up to 50% of the patient with pyelonephrosis will end up in septic shock if we do not address. And the last two lines are important. Mortality is less if we drain them. So timely referral and timely intervention is important. How are you going to diagnose? Imaging, it can be either ultrasound scan, but investigation of choice will be non-contrast CT-KUB. What are the things we have to consider in managing a patient with obstructed, infected kidneys? Number one, when do we need to intervene? Number two, what are we going to do? Number three, either it is stent or PCN or percutaneous nephrostomy. And when are we going to consider PCN rather than a stent? And how might we get it right often? Now, when are we going to intervene? The guideline says we have to urgently intervene. We have to drain them urgently. How much we load the antibiotic to the patient? It's simple as draining an abscess. If we don't drain, none of the antibiotic will work. What do we need to do? The radiology colleague will do a scan or a CT. So where is the obstruction, whether it is distal obstruction or the proximal obstruction? What is above? The kidney above the obstruction is whether it is normal, whether there is a dilatation of the system, whether there is extravasation of the fluid, and whether there is gas in the kidney or else emphysematous pyelonephritis. What is below the obstruction? Ureter below the obstruction, whether it is obstructed due to another stone, another stricture. Normal lower tract, prostate is obstructed. Any reconstruction work being done in the lower tract, or the patient is pregnant or not. What about the contralateral kidney? Whether it is atrophic kidney, whether it is smaller kidney, whether there is obstructing stone on that side also. Patient factors, again obesity, history of drugs, and performance status or ASA grade. Stent versus PCN. What is the tube you are going to select? There is lack of consensus, no clear guidelines. There is equivalent outcomes for both tubes, either it is stent or nephrostomy. So these are the studies. They have compared percutaneous nephrostomy versus stent. They have compared time to normalization of the temperature, intervention time, success rate of both the procedures, spontaneous passage of stone after the procedure, mortality, length of hospital stay, complication, and cost. Mostly you can appreciate the letters ND, no difference. Mostly there is no difference between two tubes. How are you going to decide on the tubes, whether it is stent or PCN? Always, it all depends on the patient factor and the facilities available at our center. If you consider stent, it should be done under regional or general anesthesia. We can do in a patient who is on uncoagulated patient, and urologist will decide the time frame. We don't need to depend on the radiologist. And we can do in a non-dilated system also, and it can aid for future stone management. Hope these videos, yeah. So you can appreciate here the amount of pus draining after stenting of an obstructed kidney. So this is a drainage of drainage of an abscess. However much we load antibiotic in this condition, the patient is going to stay with us. And in the second video, you can appreciate patient with emphysematous pyelonephritis. You might not see pus, but you can see the gas bubble. Because of the obstruction, gas-forming organism, there is gas in the kidney, and when you put the guide wire in the kidney, you can see the gas. So what about PCN? It can be done under local anesthesia. It is rapid decompression of the system, because you can see the length from the skin to system is lesser compared to the length from VO2 or UO to the kidney. And the size of the tube is larger than the stent. Normally we go for 8 French or 10 French nephrostomy tube, whereas we put 6 or 5 French of a stent. Can monitor the urine output, where we can assess the function of the kidney, antegrade stenting if needed, and we can use that nephrostomy tube as an entry point for future stone surgery. Yes, big salute to our radiology colleague. This is a stone in a left upper ureter, where you can see the stenting is failed, because you can see the guide wire is coiling underneath the stone because of the curved ureter impacted the stone. So where we seek the advice or the help from radiology colleague, they do a marvelous job for us. They do the scan, there's a pyelonephrosis and abscess, they drain it with the PCN. You can see the amount of pus draining after the procedure. Okay, both procedures are interventions, so as usual they will have their own complication. Risk of PCN, minor complication is more than 25%, and there is mortality of less than 1%. Again, PCN, stenting, we can appreciate there is septic shower and might need ITU admission after stenting, and there's a chance we might not be able to stent the patient, and then colonization of infection, and more than 80% of the patient might have stent symptoms. These are the situations where we prefer PCN rather than stent. Bladder-based or significant prostatic disease, sometime intravesical protrusion of the median lobe where we cannot locate the UOs. Very distal large stone, so very unlikely we may succeed with a stent. Profound sepsis not fit for general anesthesia, and diversion or irreversible retrograde excess. One slide of urethral stone, either it can be seen or visible, or it can be seen with, it can be seen or it can be palpable also. Normally, most of the time, these stones are due to drop stone from the ureter. The bladder stone de novo might not, very unlikely they drop into the ureter. Mostly the ureteric stone will drop into the ureter, will cause acute urinary retention. Most of the time, we put adequate gel. With that, patient might pass the stone, or else we push the stone back into the bladder, and we'll do a cystoscopy later on. In summary, emergencies in urolithiasis are purely due to obstruction. And obstructive uropathy is a potentially reversible condition. So we have to intervene, and please, we request all the general people to refer this patient timely to prevent permanent kidney damage. Surgical decompression of the urinary system is the key component of the care, and definitive management of the stone will be delayed till the kidney and the patient freed from the stress. With that note, I conclude my talk. Thank you very much.
Thank you very much, Dr. Thaha. Our next speaker is Professor Srinath Chandrasekera, Professor in Surgery, Wijeyaratne Medical Faculty. He is going to talk about prevention of recurrent stone formation.
Good morning, gentlemen and ladies. It's lovely to see my teacher here, Professor Sharifdeen. Morning, sir. Hope you're feeling better. Hi, Abhay. I'm going to very briefly talk about prevention of stones. Well, this is pretty much a medical topic, but I believe that many of us who are called upon to manage patients with stones, and that is not restricted to just urologists in this country. Stone disease is so rampant, as Manjula said and Thaha said, that we are all involved in managing these patients. Manjula already alluded to the high risk of recurrence, and I'm afraid I have to just make it look even worse, because in a period longer than 5 years, the recurrence rate can be as high as 50%, and in the case of uric acid, it's a near 100% unless there's intervention. So this is a very important topic for all doctors and for all surgeons, because many of us have to handle this situation. So before I talk about prevention, let's briefly look at why stones form. The key issue in lithogenesis is lithogenic urine. Just like bile, urine has various solutes like calcium, phosphate, uric acid, oxalate, which are much higher than an average person, and these precipitate under different circumstances. So lithogenicity of urine is one of the key reasons, or increased lithogenicity of urine is one of the key reasons why stones form. Now, while I say this, we must also remember that all beings, in all beings or all people, urine is anyway lithogenic. It is most of these substances that are present in urine, which I mentioned, are way above the solubility factor, so they can precipitate. But there are so many other inhibitory factors like continuous flow, lack of obstruction, stone inhibiting environments such as the presence of potassium, the pH, and so many other things that prevents precipitation. So when this balance is upset, there is a higher tendency for stones to form. So that's why many of us who are in practice believe that it is just not one factor, but a combination of multiple factors which lead to the formation of stones. And we need to be cognizant of this when we take steps to prevent them. So what are the other factors why stones form? Obstruction of the urinary system. Thaha alluded to emergencies, but things like PUJ obstruction, ureteric strictures, megaureters, and in the bladder, let's not forget bladder outflow obstruction in the aging male, or chronic strictures, which will cause stagnation, which will lead to stone formation. Infection is an important factor, and so would be foreign bodies. Stones themselves form a nidus for most stones to form, and that's called epitaxy. So all these factors need to be considered when you strategize methods of preventing recurrence of stone formation. So what are the general considerations? As surgeons, the first thing we need to achieve is complete removal of stones. Now, when doing surgery, if stones are removed and there are fragments left behind, these fragments can form a nidus for most stones to form. So that is a factor that will cause an additional risk towards recurrence. Now, there is an ongoing debate as to what the definition of a clinically insignificant stone is. I am not going to address that because there is no answer. It was usually considered that a stone less than 4 millimeters in the kidney would be considered clinically insignificant, but now this is being challenged, and the size keeps going down. And there is also a little paradox here, because with our new technologies which Manjula spoke about, the use of miniaturized equipment and laser invariably leads to dusting, and this dust can precipitate in calyces, especially when these technologies are used in the kidney. So I'm not going to talk about it because there is no clear data, but we need to understand that the bottom line is that we need to try to remove all stones, because otherwise they will form a nidus for recurrence. We also need, it is mandatory that we identify the type of stones, and this is not by chemical analysis, instead by crystal, studying the crystal structure. And I'm very pleased that now numerous centers in Sri Lanka, not in the NHS yet, but it is possible to analyze the stone composition, which is pivotal in deciding on strategies to prevent them, and of course the biochemical status. Please investigate for surgical factors, and we spoke about the surgical factors. Unless you correct them, stones will come back with a vengeance. So if there's a PUJ obstruction, doing a PCNL to remove stones will not help. If there's a calyceal diverticulum or a ureteric stricture or blood outflow obstruction, removing the stones would just be a surgical exercise just for them to recur within a short period of time. So correct the surgical causes and identify the underlying factors. Now, this is a very busy slide, just don't have to worry about it. This is from the EAU guideline. All what it says is that there are various factors that renders patients high risk of recurrence, and this includes bilateral stones, large stones, residual stones, identifiable biochemical factors like endocrine or other abnormalities. So, I mean, just to impress upon you that there are numerous high risk factors that makes it more likely that such patients will have a recurrence. Now, we do imaging to identify the stone and to identify characteristics of stones, and also for any to look for structural anomalies. Metabolically, we need to do some essentials, and these are simple things to do because we need to analyze the urine and to look for sepsis and to look for various crystals, especially if you find steroid and uric acid crystals, that is considered to be very significant. So we need to do urine analysis. We must analyze the stones for its crystal structure, because depending on what the stone is, I'll talk about this in a moment, there are different ways in which we can adopt lifestyle as well as medical measures to prevent them. We do a renal profile to look at the internal biochemistry, and this is a must in all patients. So for postgraduates who are doing MD, I think these are important tips that these are the essentials of metabolic evaluation in low risk patients. However, when it comes to high risk patients, as I mentioned, then we need to go a step further, and we do a 24-hour analysis of urine to look for specific values of excretion to see the level of uric acid, calcium, oxalate, and various other stone-forming elements to see their level of excretion. So this is the 24-hour metabolic analysis, or the extended metabolic evaluation is for high-risk patients. Now, let's also look at what we are dealing with, and this is data from Sri Lanka, reproduced. This is our own data, which was presented from Colombo South, presented at SLSE 2021, but there are numerous other studies from Sri Lanka, from Jaffna, from our own center by Anuruddha Begunasekara, which mirrors these findings. Like elsewhere, most of the stones that we are encountered with are oxalate stones. But what is remarkable, and this is a trend that is seen in the rest of the world, is that there is a high incidence of uric acid stones in its pure form or as mixed varieties. Infection-related stones, fortunately, are less in frequency now in Sri Lanka. That is probably due to better use or more rational use of antibiotics, and more importantly, the wide availability or the wider availability of surgical interventions. And the same goes for staghorns. The traditional thought of staghorns being infection-related is no more. It is certainly not so in Sri Lanka, because majority of staghorns that we deal with in Sri Lanka, and this is of this data comes from my unit of 30 staghorns from 47 operated over a period, and majority of the staghorns were oxalate. Alarmingly, a significant proportion that you see here, red, are uric acid stags, and another proportion of mixed stones. So infection-related stones, fortunately, are rare, because infection-related stones may cause greater renal damage. So what are the key steps in preventing stones? As I mentioned before, identify and treat the cause. Do a biochemical analysis, which is now freely available in all secondary and tertiary care hospitals in the country, except stone analysis. So this is a much better situation than 20 years ago. So we can do a proper analysis. Avoid residual stones. If you leave stones behind, they will nucleate, and then they will form more stones. Now let's talk a bit more about reducing lithogenicity of urine, and these are the key topics you need to remember. Hydration, hydration, hydration. There's no substitute to that. Control diet and metabolism, and lifestyle measures. And finally, I will talk about very briefly about pharmacotherapy as a measure to prevent stone recurrence. So it is important that these patients who form stones are advised to drink good amounts of water. In an average built adult, it is recommended that 2 to 3 liters of water is recommended, and this is water, not special substances, no special forms of water, just clean, pure water. More important is that this consumption of water is circadian, so it has to be drunk throughout the day in adequate quantities. There's no point binge drinking, because that will only, you know what happens if you binge drink, it will just get flushed out, and what is necessary is that there is circadian drinking and a diuresis of over 2 liters. So as much as what you drink, it is important that the patient passes adequate amounts of urine and maintain a low specific gravity of urine. So it is also important to impress upon our patients that consumption of various aerated waters, I don't want to mention trade names, because you know what they are, the brown color stuff is the worst. So commercially available soft drinks with preservatives and special substances are toxic. So you must strongly advise, and this is now shown across the world, to avoid various forms of aerated waters, which is very, very bad towards management of stones. Not going to talk about this in detail, but important. Water should be an important component of a regular diet, where there's adequate consumption, adequate hydration. All the good things are good here. So they say that a Mediterranean diet or a typical Sri Lankan diet may not be great for stones. Fruits and veggies, lots of calcium, potassium, and citrate containing fluids are good. And you see what is bad. Lots of proteins, alcohol, excess salt are bad. Now, very quickly about metabolic syndrome. You know about this, and metabolic syndrome is a key contributor towards recurrence. And certainly in Sri Lanka, we found that most of these people who form uric acid stones have some element of metabolic syndrome. So significant proportions of stone-forming patients are now found to be obese, and they excrete large amounts of stone promoters such as calcium and uric acid in particular. So we need to control their lifestyle and their diet. So further data is to show that people who are obese and and when they evaluate the risk of stones. The history of having stones in the past is twice as much, especially in males. So relationship of sodium and potassium. Just remember that sodium is bad, potassium is good. High sodium intake will lead to reduction in citrate, which is an inhibitory substance. So additional salt and excess salt intake is counterproductive towards measures to prevent stones. And potassium has an opposite effect. And this is now published, and this data or information is widely accepted. Similar with proteins. Animal proteins have a direct link to uric acid, so they need to consume animal proteins in moderation, and also protein is linked to calcium excretion. So this is all general stuff. A sensible common sense diet is important, and a diet abundant in fruit and vegetables, fresh fruits and vegetables, and avoiding aerated drinks are important for those who form stones. So finally, let me come to pharmacotherapy. This is a PhD by itself, and I'm not going to complicate matters for this mixed audience. And I've highlighted certain things that are good for people anyway. Citrate is good for almost all types of stones that are common, whether it be oxalate, uric acid, cystine, which is rare. I mean, I'm yet to see that many stones, but it's mostly uric acid and oxalate stones, or the mixed variety that we see. Citrate is good. Same with bicarbonate, which is freely available in hospitals. It is good particularly for uric acid stones to maintain the appropriate pH, and also known to be favorable for oxalate stones. Funnily, allopurinol, which is a very drug well known for the treatment of gout, is known or has been shown to be favorable in the prevention of oxalate stones as well. Well, these are long stories, but remember that these are some of the common drugs that can be used. I will also, before I finish, leave a thought with you that we find that lots of people who have stones are marginal in their serum calcium, and their vitamin D is chronically low. So we don't have comparative data to make a sort of a strong statement, but look at calcium supplementation. Contrary to common belief that calcium is not good for for stones, adequate amounts of calcium is essential, because calcium binds to oxalate in the gut and then it excretes it. So we are now in the habit of giving additional calcium, especially when people have low vitamin D and marginal serum calcium, as a measure to prevent oxalate stones. So I have highlighted the important things, and remember the story about calcium and vitamin D. So let's, in winding up, look at some of the challenges. We do not have comprehensive assessment or metabolic evaluation methods in most hospitals except teaching hospitals. But on the other hand, although it is recommended in the guidelines, our own experience, and I'm sure our urologists in the audience will agree, that extended metabolism and metabolic assessment in the Sri Lankan cohort has not yielded much results. So we don't find anything wrong. Maybe we are not doing it right, but in many centers, both in the state as well as outside, we find that the pickup rate of extended metabolic evaluation is very, very low. So this poor pickup rate is a problem, and we do not know why. We do not have stone analysis, crystal analysis, or structure analysis in the National Health Service, but it is not very expensive, and it is generally available in all major cities. So there is some hope there to get these stones evaluated to find out whether they are of one type, the other type, or a mixed variety, which is important for us to decide on preventive strategies. And of course, the biggest problem we have is the massive caseload. So to do ideal treatment, we need time, personnel, and we simply do not have that when we consider, because every casualty is 10% is due to stone and urological emergencies, and most of the emergencies that we have are stone related, and the caseload is very high. So there is a logistic problem in Sri Lanka. And last but not the least, it has been shown globally that the compliance to preventive measures in stone patients is very poor. So some considerations: does traditional medicines have a role? Do we have regional variation? So these are unanswered questions, and I leave you with these thoughts that it is a very recurrent problem, and we need to have good insights into preventing the recurrence of stones and it has to be essentially a multifaceted approach. Thank you very much.
Thank you, sir. Our last speaker of the symposium today is Professor Abhay Rane. Professor Rane has been a long-standing friend of Sri Lankan surgery and urology. I don't think he does need any other introduction. He's a consultant urological surgeon at Surrey and Sussex NHS Trust UK, and currently holds the position of the Registrar of the Royal College of Physicians and Surgeons, Glasgow. And he has a enthusiasm in education, training, mentoring, and also on neurotechnology, which I think in keeping with his topic today. Over to you, Abhay.
Thank you, Ranga. Thank you, Chairman. Welcome, everybody. It's good to be back. Second home. It's always a pleasure to come to these meetings. So, as Ranga alluded to, we're going to talk on AI and try and hone down on its applications to the management of stones nowadays. There may be some little sidetracks to that, but we're going to have fun over the next few minutes. So I have no. So is it? How do I advance the slides? Oh, okay. So I have no disclosures. So this is the long and short of the talk. I'll go back one. Kidney stone disease, how do we diagnose it? How do we predict what type of stones there are? And then look at ways in which we can treat them, look at the outcomes, what's used to get those outcomes. So if we boil down that to the nitty-gritty, there are some circles there, and those circles will determine the pace of the talk. We'll talk a little bit about AI, machine learning, deep learning, and neural networks, and those form the four components of what is used to detect stone disease, predict its management, optimize the operative procedures, and analyze the stones. So fairly straightforward. Let's talk about artificial intelligence. Everybody's talking about AI nowadays. But what is AI? What is artificial intelligence? How did it all start? So some of you may have seen the movie called The Imitation Game. It's based on what Alan Turing did in the 50s, and he was a British scientist, and he basically asked the question, can computers think like human beings? And he did a number of studies which he inputted data into certain algorithms and then asked the question, and then finally the answer was yes, they can, but we have to give them the tools to do so. So then from that we got to machine learning, which is unsupervised learning. So you give the machine data. Here you go, you can have, this bucket load of data, try and analyze it, sift it, and give me an answer. So the machine says, okay, thanks, doc, takes it on, and then churns out, using whatever algorithms we have fed into it, possible data set, which might give you the answer that you need. However, to tweak that answer, you may need to have to help the machine on. And so we're getting better. We're getting better from something where we didn't have anything, then we now have a machine that perhaps helps us by giving us some of the data we seek. Then we move on to deep learning. So this is a subfield, if you can see, of machine learning. This is self-taught. This is the computer kind of getting smarter. So this is based on algorithm layering. So the team helps the computer generate an artificial neural network, which then works independently because it's got the wherewithal within itself to actually start thinking autonomously like a human brain. So this is a big jump from machine learning to deep learning, and it works independently, and that's why you can instruct it to get and tease out data better. And it's happening. Now finally, we have a subset of deep learning, and this is, I've put this in because this bit alludes to urology, and you'll see how it, why it does. So these are complex artificial neural networks. They're created for a specific pattern. So for example, if you are having a CT and the patient moves, in the past we just had to chuck that CT away because there was so much distortion that you couldn't actually kind of get the data you wanted. However, with CNNs, they have the algorithmic ability to actually sift out that data and actually give you the data that you seek. So you can see things are getting better. Machines are from not thinking, they start thinking, then they start thinking autonomously, and they actually then improve on what has already been presented to them. So this is kind of how AI is going to currently fit into the management of stone disease. We're talking only stone disease here. There are, hundreds of different topics in surgery that AI applies to. And come to our session this afternoon, and we'll go through those with you. So let's just consider these one by one. I'm going to stick with my index slide just to give you context. So this is a paper, I think very recent, July this year, published by Darren Smith and his colleagues. And it basically simply asked the question, can AI detect urinary stones? I mean, what's the data out there? Are there any papers that will tell us that? And to our surprise, we found that, yes, it did. There's a number of studies which look into this and then give you, the percentage prediction of whether, if somebody comes in without human intervention, has a scan, and has a surgeon look at the results of the scan, the data that is presented to it, it can detect stones. So if you distill that data down, artificial intelligence, deep learning, can detect and measure stones accurately on non-contrast CT. And this stone contrast detection and management actually moves things along. The pathway moves along. So you don't really need to have that initial time wasted as to, should we order a CT? If so, who should look at it? If so, when do we get the results? If so, should it be a urologist? Should it be a radiologist? You can see what might happen. That somebody comes in with ureteric colic, has a CT, and then the machine's analyzed everything for you. And when you get to see the patient, you've got an AI-generated report saying there's a 5 millimeter stone in the lower ureter. And then it might even tell you what type of stone it might be, but we'll come to that. So it's working with the clinician to make things quicker, faster, and hopefully safer. Okay, then point 2, management. So we had some data presented by the earlier speakers. Should we do this? Should we do a PCN? Should we do a stent? Or should we do nothing for some of these stones? So the AI algorithms will tell us, based on the data you feed into them, as to whether we would be able to manage them successfully just by perhaps seeing whether the stone passes without any intervention. Now, we know from historical data that 80% of stones that are 4 or 5 millimeters or less will pass. But what we don't know is how long it takes to pass. And we don't know how much pain that patient might have while he's waiting for it to pass. The algorithms give us that, sift it down, individualize it for the patient, and then tell us what the outcome might be. And then there are different algorithms that look into that. If you're giving somebody SWEL, for example, and if you're operating on that patient. So it just gives you a better idea of how you can tell the patient, maybe I'll get you stone free, or maybe you'll have to come back for further treatment. And this is just that busy slide that kind of puts all of what I said earlier into perspective. It hasn't projected very well, but that's part of it. The interesting thing here is that it will tell you also how you can make your operative procedure better. So there are different, how many shockwaves perhaps you should give for this particular stone. What should be the gating interval? If you're going to use energy for breaking up the stone, perhaps what sort of energy would be best in this case? So all of this comes from data that is historical, but it is then now being analyzed and rationalized so that you can use AI to help you plan your treatment going forward. And finally, as Srinath alluded, there's stone disease chemistry and composition. So, I mean, sometimes it's difficult, as he said, to get stone analysis and stone chemistry. AI is going to make that very much easy for you. So look at this. These are images. You look at it. If your camera is plugged into the adequate rendering software computer, as soon as you visualize it, you'll get a likelihood of this being either a monohydrate stone or a dihydrate stone or a carbonate stone. This is AI telling you this just by looking at it, because it's analyzed the data from thousands of images, and so now we have a predictive stone composition model. So you can see suddenly everybody is kind of in a happier place, because we can now initiate stone-specific treatment without any wait. So this isn't the future. This is now. It will get better. This is a very busy slide, and basically it all distills down to one point. AI in endourology is getting better. If there wasn't any interest in it, and if it wasn't getting better, we wouldn't get more and more articles. I think urologists are generally good at this. We pick up on data, and we pick up on machines, and we're good with our hands, and so we're arguably, kind of a little bit ahead of the curve, although I would say that as I'm biased. Lots of other surgeons here, I know that. But we are receptive to change, and that's why I think we've kind of worked with our colleagues, our computer engineers, and we've come up with these algorithms that are going to help us. There are a couple of papers that I'd refer you to if you want to have a look at. Now, there is ChatGPT, everybody knows that. There is also UroGPT, free. You can download it if you're a patient, and you can ask UroGPT, what shall I do next? And it'll keep on telling you. It can only go so far because it's based on predictive modeling, but you can try it out, and it's pretty slick. So, this is the sort of thing that I think will become commoner as time goes on, because everybody carries a phone now. Everybody has WhatsApp. Many of you have some sort of AI ChatGPT or something like that already installed on your phone. So patients will be looking at something like this. The most important thing is you can use it to tell patients what to do next, as part of your algorithm, and it can be tweaked individually. So exciting times. The last two slides are more of a philosophical overview. AI is here to stay, and anybody who thinks it's not is in for a big surprise. Any technology has both its fanatic adapters, and then there are people who are doubters. But I've seen these 4 stages of acceptance with a number of stages of surgery we went through. I saw it when we went from open surgery to endoscopic surgery, and I saw it when we went from endoscopic surgery to laparoscopic and robotic surgery. And I think the same thing will happen here. So bear with me. What happens first when I tell Srinath, we're not going to do this open surgery operation. We're actually going to make a hole in the kidney. We're using a telescope. And I'll say, are you mad? I mean, how do we do that? Kidney will bleed, you know. There's no safety in that. Never fly. Don't do it. A few years later, you've done a few, and then patients have bled, and then they say, oh, that's Srinath. He's trying to stick a camera into a kidney. No wonder this has happened. It's not a bad idea. I said it was a bad idea. It's absolutely dangerous. And then Srinath does another 50 cases, and then somebody else says, well, actually, might work. You know, it's possible. You know, limited application, small stone, you know, easy cases. And then the final one, after Srinath has done 100, he says, yeah, it's fantastic. You know, I actually proposed this 10 years ago. So you can see how things change based on how the situation progresses. And this is true. You can put this in. If you look at your specialties, all of you, I know many of you are not urologists, it actually is true for a number of specialties. Everybody doubts you, and then by the time you got to the end and you've proven that you were successful, they said, yeah, that's fine. I mean, I saw that firsthand when I did the single port nephrectomy, and I proposed it, and they said it never happened. It's just too dangerous. So I saw all of these 4 steps between the time I proposed the single port procedure in 2000 and by the time I did it in 2007. But this has been going on for generations. So just thought I'd put this in here. Anyway, thank you so very much. I'd like to take this opportunity to thank all of my friends who are here. I've thrown in a bit of Sinhala there, Kamasthiti. Thank you so much for all of your attendance. You know, we'd like to close this session, I suppose, now. Is that right? Thank you.
Thank you very much, Professor Rane.
Thank you, sir. Ladies and gentlemen, that concludes the Symposium on Renal Stone Management. I cordially invite the chairpersons, Professor A.U.B. Pethiyagoda and Dr. Rangama Wickramaarachi, to award the certificates and tokens of appreciation to the resource persons. Dr. Manjula Herath, Dr. Thaha M Musthafa, Professor Srinath Chandrasekera, and Professor Abhay. Chairpersons for their invaluable contribution, I invite Dr. S. Jibra, Senior Consultant Surgeon, Teaching Hospital Batticlaw, to award the certificates of appreciation to our chairpersons. Professor A.U.B. Pethiyagoda, Dr. Ranga Wickramaarachi. Thank you very much, sir. Ladies and gentlemen, that concludes the morning session here at Eagle Hall. Next, the prestigious Sir A.M. De Silva oration is currently being held in the Peacock Hall on the first floor. This will be followed by tea served here at the Eagle Hall. We also invite you to visit the trade stalls here at Eagle Hall, where you can participate in exciting raffle draws. Tea will be followed by 2 plenaries in the Peacock Hall. The afternoon session here at Eagle Hall will commence at 12:30 p.m. sharp, and we request you be in your seats by that time so we may stay on schedule. We hope to see you then. Thank you very much.